already discussed.
Okay.
So welcome everyone, and thank you so much for being here. My name is Jess Pelletier. I'm the medical director for Techies Without Borders. We run the Continuing Medical Education Solutions, or CMES program. And we're super excited today to have a guest lecturer, Dr. Dhiren Kumar, who is a transplant nephrologist. He is good friends with Manoj Thomas, who I'm sure a lot of you know that name, but Manoj is our head of IT, our president, and one of our co-founders. And we're super excited for Dr. Kumar to share his expertise. I am going to turn off my video just so I'm not using up your data and bandwidth, but I will be here in the chat if you have questions throughout the session, and we'll try to keep this engaging and involving a bi-directional discussion. So without further ado, go ahead, Dr. Kumar, and thank you.
Thank you. My name is Dhiren Kumar. I'm from Richmond, Virginia. I'm a nephrologist by trade, and I specialize in kidney transplantation. So as I mentioned to Dr. Pelletier, this is an honor to present this to you all, and it's something that I've been looking forward to. So thank you for having me, and thank you for attending. Oh, no, it's not. Okay, there we go. So I wanted to use this forum to present a few cases, and we will discuss the cases and what I really, I mean, my slides may be a little bit wordy, but what I really want to pass on the process of diagnosing without too many diagnostic tools in these particular cases. And being a nephrologist, I also wanted to introduce the role of dialysis, if available, in treating these toxic alcohol intoxications. So welcome everyone. So we'll start with the first case. Seen kind of periodically in emergency rooms everywhere. This is a 42-year-old male who has a history of chronic alcohol use, no other medical history as such, and presented with a chief complaint of intractable nausea and vomiting, progressive confusion, and most importantly, blurring of vision. The report we get is that the symptoms started about 12 to 24 hours after ingestion of suspected adulterated alcohol. And the main presentation was, progressive visual disturbances to the point that there was blurred vision, double vision, and then suddenly there was vision loss. There was associated headaches, abdominal pain, and vomiting. To rule out other causes, there was no history of trauma, there was no history of seizures associated. So moving on to the physical exam, the patient appeared confused, restless, slightly hypotensive, slightly tachycardic. And on a neurological exam, there was some mydriasis bilaterally, sluggish pupillary reflex, and there was cyanosis of the extremities, but there was no JVD that was seen. So that's case one. And the way I want to kind of present this is to compare and contrast these cases and see what the differences are with each case. So case two is a 45-year-old male. He's an auto mechanic, also with alcohol use disorder, and was found unconscious at home. And there was an empty antifreeze container nearby. So the onset was approximately 8 hours is what is estimated from ingestion, and they suspect it was antifreeze or ethylene glycol. There was nausea, vomiting, confusion, and which eventually progressed to stupor. Again, no history of trauma or seizures. He also is tachycardic, slightly hypotensive, is progressively becoming stuporous, and requires airway protection. And there are crackles on exam. His tachypnic reflexes are depressed, and but overall there are no focal deficits. So it's somewhat a very similar presentation, with the highlights being that there is some degree, some exposure to a toxin, alcohol-related toxin. There is progressive confusion, and in one case, loss of vision. Another case, just primary presentation is confusion. So very similar presentations where raises your eyebrow that there is some kind of toxin ingestion that is going on. So now I'm going to compare and contrast the initial labs that we got in these cases. Both the cases were severely acidotic. They were trying to compensate from a respiratory standpoint, so the PCO2 was low. There was obviously consistent with metabolic acidosis, the bicarb was low. Electrolytes, the sodium, potassium, fluoride was pretty much similar. As expected, the bicarb was low in both cases. And when you calculate out the anion gap, there was a significant elevation in anion gap with an anion gap of 28 in case 1 and 32 in case 2. So indicating that this was a severe anion gap metabolic acidosis. Now, there were some slight differences. There was some mild ketonuria in case 1, and there was no glycosuria. But in case 2, there was noted to be hypocalcemia was noted. And the urine sediment was consistent with some calcium oxalate crystals that were present. As an additional, because the patient had acute vision loss in case 1, there was an MRI done and a fundoscopy exam done on case 1, where there was necrosis of the putamen bilaterally, and there was optic disc edema seen in case 1. So overall, the presentation was very similar, except for the loss of vision in case 1. And on labs, similarity was that there was severe anion gap metabolic acidosis in both cases. However, in case 2, there was hypocalcemia, there was AKI, and there was calcium oxalate crystals that were present. And what I want to do is to keep these similarities, but more importantly, these differences in mind as we go through the pathophysiology of how these toxins are metabolized and in our body, and also plays a role in the treatment, in deciding the treatment for these patients. So as you can see here, in case 1, there is papillary, there is optic disc edema. And on MRI, you can see atrophy of the optic nerves. Similarly, on an MRI in case 1, you can actually see necrosis of the putamenal areas in the brain. Whereas in case 2, the putamen is not is spared, but there is thalamic necrosis that is seen, or hemorrhagic changes in the thalamus that is seen. So there is a difference between one particular toxin leads to vision disturbance due to optic nerve atrophy, and also necrosis of the putamen, which is sometimes almost a pathognomic finding in methanol intoxication. However, in case 2, there is more thalamic destruction and hemorrhage that is seen sometimes in advanced cases. However, in case 2, the urine sediment does show significant calcium oxalate crystals, and these can be either the envelope kind, or these can be needle kind that are seen in the urine. So, which is almost exclusive to this particular toxin as compared to case 1. So some mild differences, even though the presentation is confusion and altered mental status, there is some focal findings in case 1 that were not present in, and that are usually not present in case 2. So I'm going to introduce a third case now, which is again, and I hope to tie it all together in the end. Case 3 is a 45-year-old male, again presenting with the same presentation, altered mental status and vomiting. And he had an empty bottle of isopropanol right next to him where he was found. And the ingestion was approximately 2 hours in an attempt to commit suicide. There is no other medical history, no diabetes, no other chronic illness. The patient presented with relatively stable vital signs except for the tachycardia. There was ataxia, there was confusion, slurred speech, and importantly, it was noted that the breath had a fruity odor to it. There was only mild tenderness, but no guarding or peritoneal signs on the abdomen. However, it was noted that there was melanotic stools noted on rectal exam. That was quite different from the other two cases. So again, very similar presentation, similar vital signs, but in this particular case, the differences were there was a fruity odor, and then there was melanotic stools noted on exam, concerning for a GI bleed. In this case, there was evidence of acidosis. There was, slightly low bicarb, some metabolic, some respiratory compensation. The anion gap was slightly elevated also, not as high as the other two cases where it was above, almost above 30. But what was unique about this case was that there was significant, so there was not a significant gap acidosis. So that is unique from the case 1 and case 2. But what is unique about this case compared to the other two cases was the fact that there was significant amount of ketones noted in the urine, as seen here on the urine dipstick. So easily available, a urine microscopy is easily available, relatively speaking, and urine dipstick is easily available. And obviously, these labs are easily available. So that's kind of easy to obtain pretty quickly in an emergency setting in these presentations. So I'm pretty sure everybody has already, guessed from the hints that I've presented, is that, case 1 is methanol toxicity with the blindness and the anion gap acidosis. Case 2 is ethylene glycol, automechanic, and an antifreeze found next to him. And case 3 is rubbing alcohol ingestion as a suicide attempt would be isopropanol ingestion. So these are probably the most common alcohol toxins that we come across in an emergent setting. And what is important to identify is a lot of this requires a high degree of clinical suspicion using readily available labs, because the lab levels for methanol, ethylene glycol, and isopropanol are really not readily available, and they take days, if not almost a week, to come back. So really of no acute use. So the diagnostic challenge is primarily diagnosing these based on readily available tests pretty quickly. So presentation issues are usually, the identity of the ingested substance is often not known. The patients are unable to give a reliable history, so you need some additional information from either family or EMS staff that are accompanying the patient as to the circumstances around how the patient was found. Direct assays, as I mentioned, are not useful acutely because results take a long time to come back. And then this is the classic triad, right? Like, because you don't have adequate information from the patient, the assays take forever to come back, and there is a significant urgency because there is severe acidosis. There are some irreversible damage with respect to renal failure, blindness, that can be reversed if we recognize these entities pretty quickly and treat appropriately. And in these triad of cases, the osmolar gap and the anion gap and the acid-base status not only help us with the diagnosis, but also help us with the urgency of therapy and how we engage therapy in these particular situations. So overall, methanol or wood alcohol, a common windshield washer fluid, is found in industrial solvents, but most commonly it's a cheap available recreational intoxicant, and sometimes it's labeled as moonshine in the US, at least. I don't know how it's labeled elsewhere. And ethylene glycol is found in automotive antifreeze, in brake fluids, some industrial consumer products, and basically it's found in any product that needs to be resistant to freezing or cold temperatures. And isopropanol is a clear, colorless liquid with a fruity odor and a mild bitter taste. It's found in multiple household cleaners, and is easily accessible. And the important thing to recognize is these are all commercially available. These are all very easy to access for patients who want to either use them for recreational purposes or for any other purposes, or for unintentional overdoses. So what I want to do is to kind of just to recap. Case 1, case 2, methanol, ethylene glycol had an anion gap metabolic acidosis with an osmolar gap, whereas case 3 did not have a significant acidosis, but we will calculate the osmolar gap later. What is important in this pathophysiology is to note that methanol is converted by alcohol dehydrogenase to formaldehyde, which is then converted by ALDH to formic acid. So this is an acid that contributes to that anion gap metabolic acidosis that we are talking about. Same thing as in case 2, ethylene glycol. ADH converts into glycoaldehyde, and ALDH converts into glycolic acid and oxalic acid. And again, these are acids that cause this anion gap acidosis. And isopropanol is converted by the same enzyme ADH to acetone. So that is not a strong acid at all. So therefore, it does not give that anion gap acidosis that the other two cases cause. So all 3 cases will cause an osmolar gap, but the first 2 cases will cause an osmolar gap and an anion gap, whereas the third case, the isopropanol, will not cause an anion gap. So that is one important way you can differentiate isopropanol from methanol or ethylene glycol. One caveat that I will mention is that isopropanol is associated with significant degree of hypotension, and that's kind of one of its prognostic signs also. So if there is an anion gap acidosis associated with that is usually explained by an elevated lactate and hypoperfusion. So it's not an absolute that there is no anion gap acidosis, but if there is hypoperfusion and elevated lactate, and that can explain the anion gap acidosis, then that can coexist with isopropanol toxicity. But I want to keep in mind the access points that we have here. We have of therapy. We have ADH in all 3 cases and access points. What we have to differentiate is that the toxic product here in methanol toxicity is formic acid, which leads to blindness. Ethylene glycol, the toxic process, is oxalic acid. So whatever intervention that you can do to reduce this conversion to these toxic compounds is very, very important. Now, isopropanol is actually toxic in itself. Acetone is not, and is actually readily released through the kidneys or with through the breath or through ventilation, through breathing. But the situation here is that isopropanol is actually the toxic component here. So let's keep this in mind. I'll keep reintroducing these pathophysiology processes as we go. So calculating the osmolar gap, I think we are all well aware of this formula. A lot of times these cases are associated with concomitant ethanol exposure also. So ethanol can be included in the calculated osmoles also. But the important thing to do is to get the measured serum osmolality in these cases. So in cases where ingestion is suspected, in cases where there is unexplained metabolic acidosis, in cases where there's unexplained altered mental status, or edema on brain imaging, always it is always important to calculate the osmoles and then compare it to the measured osmoles. Usually the gap should be less than 20, but in these cases the osmolar gap is very, very high. So in these two cases, case one, which was methanol, pH acidosis was present, anion gap was present. The measured osmoles were 340, the calculated osmoles were 300. Therefore, the osmolar gap here was 40. What was unique about this case was there was vision problems and optic disc edema and putaminal necrosis. So, summary, always suspect methanol poisoning in patients with unexplained metabolic acidosis and visual complaints after alcohol ingestion. That is kind of the uniqueness about this particular case. Case two, again, similar acidosis, anion gap acidosis, an elevated osmolar gap of almost 55. But let me just go back here. It forms oxalic acid, ethylene glycol. What this oxalic acid does is it binds to calcium and forms calcium oxalate. Thereby, in the serum, you see hypocalcemia because of that oxalic acid being produced. And also in the urine, you see calcium oxalate crystals. And these calcium oxalate crystals then deposit in the renal tubules and cause an AKI. So therefore, AKI, in the absence of hypoperfusion, AKI as present in a case should clue you into thinking about calcium oxalate crystals and ethylene glycol as the cause of this. So overall, in summary, always suspect ethylene glycol poisoning in patients with unexplained metabolic acidosis, hypocalcemia, and calcium oxalate crystals. So finally, case three, there is a degree of acidosis that is present. Anion gap is not too elevated, but the osmolar gap is significantly elevated. And as we look here, acetone is the end product which is eliminated by the kidneys and by respiration. So therefore, there are high urinary ketones. Acetone is ventilated out, so there is fruity odor to the breath. And ethylene glycol actually causes gastric hemorrhage. This I did not know until I reviewed this, made this presentation. So it can cause gastric hemorrhage, and therefore, if there's melanotic stools associated with an osmolar gap, always consider isopropanol as the cause. So overall, always suspect isopropanol poisoning in patients with an unexplained osmolar gap without a significant metabolic acidosis and large ketones in the urine. And it also causes hemorrhagic gastritis. So I just want to highlight the similarities of these cases, but also you can use, presence or absence of anion gap, calcium oxalate crystals in the urine, fruity odor in the breath, urine ketones, loss of vision as clues that can guide you towards one therapy, one ingested toxin or the other. So now with the next part of this presentation, I will go into a discussion of each toxin and explain, what we can do with respect to reversing therapy, treat, and also buying time. So methanol, as I said, converts to formaldehyde by ADH and then eventually formic acid, which is quite toxic. So we have a target of intervention here: avoid or delay this conversion. Use up alcohol dehydrogenase some way that it does not bind to methanol. So methanol presents first less than 6 hours, inebriation, drowsiness, high osmolar gap, high methanol level, which we most of the times don't have the luxury of having. Progresses to optic toxicity, which is blurred vision from formaldehyde and high osmolar gap. And then by third stage, there is abdominal pain, nausea, vomiting, seizures, coma, and death. And by the third stage, we start seeing high lactate levels also due to the hypotension associated with these. So the first step in all this, before we even start thinking about dialysis and stuff like that, is to prevention of metabolism. So overall, plasma methanol concentration of greater than 20. I've just added that, but most of us, by the time we're making these decisions, we don't have this information. If there is a significant recent history of methanol injection with an osmolar gap of greater than 10, you need to initiate therapy. A pH of less than 7.3, a bicarb of less than 20, and an osmolar gap of greater than 20, we need to consider initial first-line therapy. So now we have the expensive stuff, which is fomepizole. And the reason why fomepizole works is because it has almost 8,000 times higher affinity for ADH. So when fomepizole is introduced in the system, it preferentially binds to ADH at a much greater level than either ethanol or methanol. And as a result of which, it prevents this metabolism to formaldehyde and formic acid. And in the US, this is readily available now, and so therefore it pretty much is the first line treatment in 90 to 95% of the cases. However, it is expensive compared to ethanol, and obviously it's a treatment of choice. In resource limited settings or access settings, ethanol therapy is the second best option. Again, ethanol still binds at a higher affinity to ADH than methanol, not as good as fomepizole, but still better. And if given by an IV infusion, it needs to be monitored as compared to fomepizole. It does not need to be monitored. The levels need to be monitored, but it is cheap, effective, and readily available. However, the drawbacks are that it requires frequent monitoring. There is, in a patient that already has altered mental status, it could worsen the process. In the US, it requires ICU level monitoring, and in the US, it's not FDA approved yet. But in the absence of fomepizole, this is a good alternative. When does dialysis come into play? And I hate memorizing guidelines, but I like to keep a gist of like when you are in these situations. Effectively, what these guidelines suggest is that by the time you're having neurological compromise, it's time to bring in, and it's identified that it's methanol and high osmolar gap. It's time to bring in dialysis and an adjunct to first-line therapy as preventing conversion of methanol to formic acid. Development of shock, development of other complications, development of renal failure, time to bring in dialysis to assess this thing. And so if the people have consumed a significantly high levels of methanol, time to bring in dialysis sooner rather than wait for things to evolve. And again, they mentioned a methanol level of greater than 16 millimoles per liter, but this is not really important. The on dialysis, the closure of the anion gap needs to be monitored. The osmolar gap needs to be continuously monitored, and to determine the duration of the dialysis therapy. So folic acid apparently has been shown to increase the metabolism of formic acid to CO2 and H2O. So that can also be used as an adjunct in addition to dialysis. So overall, I think the major message is that suspected ingestion, initiate at least prevention of conversion, prevention of metabolism early, depending on what is available. And then if there is a significant neurological compromise, or if there is significant hemodynamic compromise, these are the times to bring in, or if there is a indication that there has been a significant ingestion, time to bring in dialysis sooner than later. And monitor the same parameters that allowed us to diagnose this, the osmolar gap, the anion gap, to determine the duration of dialysis. The second case was ethylene glycol. Again, similar kind of progression within 30 to 12 hours of injection. And the thing about all these three is they're rapidly absorbed. So gastric lavage, or by the time the patient comes to your attention, pretty much all that ingestion is already absorbed within 2 hours. So stage 1 occurs within 30 to 12 hours after ingestion, is characterized by slurred speech, ataxia, development of the acidosis, and CNS depression. By 12 to 36 hours, rapid tachypnea develops, cyanosis and pulmonary edema starts happening, probably related to significant hemodynamic compromise and capillary leak. And then by 2 to 3 days, progressive renal failure develops, including proteinuria, oliguria, and anuria, likely related to either shock or, more importantly, the calcium oxalate crystals depositing in the kidney. Again, similarly, we have the same targets here. You want to prevent metabolism, so ADH is your target to prevent metabolism. And again, the criteria are high ethylene glycol levels, which are not available, but high osmolar gap, severe acidosis, low bicarb, very similar to the methanol criteria. And again, similarly, blocking ADH is our way to prevent these toxic metabolites from forming. Therefore, either fomepizole use if it's available, or ethanol use if it's available. Charcoal, if the patient comes in early, may be of some benefit, but by the time the patient is brought to us, it's been at least 1, 2, if not several hours since ingestion. So overall, it's not the first line therapy, just because of the circumstances. Then, with respect to recommendations of dialysis with respect to ethylene glycol, again, it's tough to memorize. I hate memorizing stuff. So it's, again, severe acidosis with end organ damage. So severe acidosis with renal failure, severe acidosis with progressive neurological decline. And then there are these levels that are used. But again, I think it's more got to do with the degree of severity that you're dealing with. So if the acidosis is persistent, if the renal failure is progressing, if the mental status is declining further, time to bring in dialysis sooner rather than later. Finally, the third case is isopropanol or isopropyl alcohol. Again, very readily absorbed in the GI tract, as I mentioned. CNS symptoms very similar. Has a slower half-life, and it's excreted. Acetone is excreted by the lung and the kidney. And ADH metabolizes the same thing. So again, as I mentioned earlier, the parent compound, as compared to the other 2 cases of methanol and ethylene glycol, here the parent compound is the problem, not necessarily the metabolite. So there is no reason to block ADH at all with ethanol or fomepizole. You actually want to promote this conversion so it can be actively eliminated. So again, as I mentioned earlier, hypotension is a very strong predictor of mortality and can cause severe lactic acidosis. So, but ADH inhibition is not indicated. Acetone is less toxic than the parent compound. HD determination is, again, here these concentrations, but basically what we come down to is when you're dealing with these patients, if there is hemodynamic instability, if there is neurological instability, or most importantly, if there's renal failure. In this particular case, the kidneys are a process of elimination, which is if there is progressive renal failure due to hypotension and hypoperfusion, then HD should be is indicated to remove the compound. And again, following the osmolar gap in these particular situations, following the resolution of acidosis, will determine the duration of dialysis therapy. So I think this is kind of an overall guideline review. Jess, do you want to jump in here, or I can continue?
Can you hear me okay? Yeah, I can jump in here. So I just wanted to quickly go over what the Ugandan and Gambian clinical guidelines have to say. So the Ugandan guidelines recommend specifically for methanol poisoning to pursue gastric aspiration and lavage if it's within 2 hours of ingestion, just to help reduce absorption. And they do remind us that charcoal is not useful here. They recommend using alcohol. And from an oral perspective, I know in my setting we have an option for IV alcohol if fomepizole is unavailable. available, but it sounds like oral alcohol would be the preferred method here. That's going to be a little bit challenging if the patient's altered, so probably would need to use a nasogastric tube, and potentially they would need to be intubated if they're incredibly altered. And then sodium bicarbonate drip is an option if they have severe acidosis. And obviously checking for hypoglycemia is key for any patient with altered mentation. They did not have a section for ethylene glycol or isopropyl alcohol in the Ugandan or Gambian clinical guidelines, only methanol. So I am curious if someone wants to chime in the chat, if methanol seems to be more common in your settings than ethylene glycol, since that wasn't mentioned in the guidelines. Dhiren, do you mind advancing one slide for me?
Yeah. There we go.
Perfect, thank you. Pretty similar recommendations here from the Gambia. So gastric aspiration and lavage only within 2 hours of ingestion. And then they also recommend using sodium bicarb, but here they're suggesting using it orally if I'm assuming that if you don't have IV access or IV sodium bicarb accessible. And then in severe cases, you can use sodium bicarb for severe acidosis. And they are recommending oral alcohol. So again, would need a nasogastric tube if the patient is altered in any way. And then obviously referral to a tertiary care, so an advanced hospital if you are working out somewhere in a more rural area. I know in the Gambia, nephrology can be hard to come by. I think there's only one nephrologist for the whole country, and dialysis is only available at Edward Francis Small Teaching Hospital, to my knowledge. I don't think we have anyone from the Gambia on today. I would love to hear from some folks in Uganda what your accessibility is in terms of fomepizole. I heard one person respond in the chat that that is a rare thing in terms of availability, and usually it's going to be alcohol. Are you giving alcohol like ethanol IV or orally in the setting of toxic alcohol ingestion? Feel free to chime in the chat. I'll let Dhiren move forward to the take-home points, and then we'll actually do some quiz questions.
Okay. Let me see. So overall wrap up is it's why we are physicians, clinicians, and providers is because these are difficult diagnoses to make, and they are also there we are fighting against the clock with respect to these diagnoses. But once it is made, and as I saw somebody mentioned about a isopropanol ingestion, once it's recognized and the patient has a good outcome, it can be very, very rewarding. But the important thing is, recognize key signs of toxic alcohol poisoning. I think in the setting of anion gap and osmolar gap should be checked, especially in presentations where either an ingestion is suspected or there is depression, psychiatric disorder, or there is evidence of altered mental status which cannot be explained for any other reason. Ethanol is a viable treatment option in resource limited settings. And again, dialysis can be life-saving, especially in severe cases. But again, accessibility is always an issue. And so overall, I think guidelines, local treatment guidelines are very, very important because they do take into account the availability of the resources that are there. So again, that's that.
Awesome. Thank you so much to Dr. Kumar for sharing his expertise with us today. We are going to do a quiz to see what you've learned. So I'm going to hit launch, and we'll give you guys a few minutes to fill this out. This is not a test for points. It's for formative purposes, so for your learning. So we'll give everyone a little bit of time, and then we'll discuss the answers. So feel free to go ahead and answer these quiz questions that just popped up on your screen. I have pasted the link to our post-participation survey. We would be greatly appreciative if you can fill that out. It helps us to continue making these sessions better for all of you. It helps us to pick topics that are useful and to present in a format that's helpful for you. And in the meantime, while people are filling out these quiz questions, feel free to keep writing in the chat what you do in your setting in terms of toxic alcohol ingestions. I am curious if anyone has dialysis immediately available for their patients with severe ethylene glycol ingestions. are you using dialysis, or are you primarily using bicarb drips, NG, ethanol, and that sort of thing? I see some people responding. Thank you so much. Keep on answering these questions for us. Looks like 3 of you have filled out the poll. Thank you so much. We'll give it another 2 minutes or so. All right, Lois says that dialysis is not easily accessible. Lois, I'd love to hear, are you primarily using oral alcohol, and are you giving it by NG tube as well?
Oral alcohol by NG tube.
Okay, all right, thank you.
Yeah, I think when I was training back at the VA hospital here, we would use oral alcohol also, and most of the times we ended up having to use NG tube.
Wow. All right, looks like 4 of you have filled out the quiz. Oh, thank you so much. It looks like there was an issue with the survey link, so I'm pasting the link again. It should be working now. Sorry about that. And thank you so much for trying to fill it out, Isaac. All right, we're going to end the poll, and I'm going to go through the answers to these questions. And I will share the results so you can see them. So, which clinical feature strongly suggests methanol poisoning? And the majority of you got that correct. It would be visual disturbances and optic disc edema. Remember that the calcium oxalate crystals are more common with ethylene glycol, the large urine ketones with isopropyl alcohol, and the same thing, hemorrhagic gastritis is more common with isopropyl alcohol. What is the most practical diagnostic tool for toxic alcohol poisoning in resource-limited settings? And the answer here would be osmolar and anion gap, and you all got that correct. Gas chromatography, direct methanol level measurement, and MRI brain are not as commonly accessible. Which antidote is preferred for methanol and ethylene glycol poisoning? And I love that half of you answered ethanol and half answered fomepizole. The board exam answer would be fomepizole, but in all of your settings, ethanol is the more realistic option given lack of availability of fomepizole. And so ethanol via NG tube would be the preferred option in your setting. When is dialysis indicated in ethylene glycol poisoning? And majority of you got this correct. You said persistent metabolic acidosis despite therapy. It looks like 1 person answered anion gap less than 12. Remember that that would be a normal anion gap. So a severe elevated anion gap acidosis despite therapy would be our indication. And then presence of fruity odor on the breath is just caused by ketones in the setting of isopropyl alcohol ingestion. That's not going to be an indication for dialysis, and neither would an elevated osmolar gap. And finally, which toxic alcohol causes an osmolar gap, but not an elevated anion gap? And this is a question I've had on my board exams multiple times. So isopropyl alcohol is going to be the answer here. Remember that methanol and ethylene glycol both cause an elevated osmolar gap and an elevated anion gap. So the weird one here is going to be isopropyl alcohol. Thank you again so much to everyone who participated and was busy answering and asking questions in the chat today. To those of you who participated in the post-participation quiz, I'm posting the link to the survey one more time, and I'll also send it out via WhatsApp. And I want to thank Dr. Kumar again so much for sharing his expertise with us. Thank you, Dr. Kumar, for being here today.
Oh, thank you for having me. This was excellent. Thanks.
Awesome. Thank you, everyone. I hope you have a wonderful rest of your day. We will share the recording link once it is up on YouTube, and we'll also share a quick summary of the session. Have a good rest of your day.
Thank you.